Image analysis on abdomen and soft tissue neck with Brandy Jones. Respiration. From full inspiration to expiration, the diaphragm position moves in the vertical dimensions as much as 4 inches. The movement also changes the pressure placed on the abdominal structures. On full expiration, the right side of the diaphragm dome is at the same level as T8 or T9, whereas inspiration, it may be found at the level of T12. Expiration is preferred for the AP abdominal projection because it places the less diaphragm pressure on the abdomen organs, resulting in more space in the peritoneal cavity and less abdominal density. Image 1 is upright abdomen taken after full inspiration. And image 2 is expiration, and you can see the diaphragms at T9 there. Abdomen AP projection supine, aka KUB. Here is a image of correct positioning and a picture of the centering and positioning of the patient. AP projection supine AKUB, abdomen image analysis criteria. Spinous processes are aligned with the midline of the vertebral bodies with the pedicles at equal distance from them. Iliac wings are symmetrical. The sacrum is centered within the inlet of the pelvis and is aligned within the symphysis pubis. L4 is at the center of the exposure field. You want to center your central ray perpendicular to mid-sagittal plane at the level of the iliac crest. T12 and the lateral soft body tissues, the iliac wings, and the symphysis pubis are included within the exposure field. Diaphragm domes are located superior to the 9th posterior rib and take the exposure after full expiration. AP supine image analysis practice, KUB. Analysis, the symphysis pubis is not included on the projection, so the CR was centered superiorly. Correction, center the CR 1 inch inferior to the iliac crest. Abdomen AP projection, the upright view. Here is an example of positioning, accurate positioning for this, and an x-ray showing you accurate positioning. Here is the image analysis criteria for the abdomen upright. It's always good to have a arrow marker or a word indicating that this was the erect position, although you should see air fluid levels and that should give you the indication that it was erect, but it's better safe than sorry. Spinous processes are aligned within the midline of the vertebral bodies with pedicles at equal distance from them, just like the KUB. Iliac wings should be symmetrical. The sacrum is centered within the inlet of the pelvis and aligned within the symphysis pubis. However, you should not be seeing the symphysis pubis on this view. L3 is at the center of the exposure field. Place the top of the IR at the level of the axilla, not the top of the collimator light field. Please make sure you know the difference. T8, the lateral body, soft tissue, and iliac wings are included within the exposure field. Diaphragm domes are located superior to the 9th posterior ribs, and they should be the diaphragm should be visible on this view. AP upright abdomen image analysis practice number 1. Analysis. The domes of the diaphragms are not included on this projection. The CR is centered inferiorly. So we should be 2 inches above the crest, and we are not. Correction would be center the CR, IR appropriately to 2 inches superior. As you can see with the X I have drawn on this image and located where T12 is, we don't even have the diaphragms on here. This is unacceptable and would have to be repeated. AP upright abdomen and image analysis practice number 2. Analysis of diaphragm is at level of T11. The projection was taken on inspiration. You really want to take this exposure after full expiration. AP abdomen projection, left lateral decube. Here is a excellent example of positioning of the patient and an image to show you the anatomy as well. An arrow, a word marker indicating that the right side of the patient was positioned up and away from the imaging cart or table is present. You always want to perform a left lateral decube. So it should always be left side down, right side up for abdomen. Spinous processes are aligned with the midline of the vertebral bodies with pedicles at equal distance from them. Iliac wings are symmetrical. L3 is at the center of the exposure field. Place the top of the IR at a level 2.5 inches superior to the xiphoid. I've never heard it explained that way, but usually it's the same as your erect. It would be 2 inches above your iliac crest. So you kind of want to start with the IR at the axilla, using a horizontal beam, of course. Center the mid-sagittal plane to the IR. Density is uniform across the abdomen. The diaphragm domes are located superior to the ninth posterior rib. Take the exposure after a full suspended expiration. Demonstrating intraperitoneal air. In the AP decubitus position, intraperitoneal air will rise to the highest level, which in most patients it means it moves to the right upper quadrant just below the elevated hemidiaphragm, between the liver and the abdominal wall. The left over the right lateral decubitus position is chosen to place the gastric bubble away from the elevated hemidiaphragm, preventing it from being mistaken for intraperitoneal air. For intraperitoneal air to be best demonstrated, the patient should be in the left lateral decube position for 5 to 20 minutes before the projection is taken, allowing enough time for the air to move from the soft tissue and the structures to rise. The AP decubus projection is primarily used to confirm the presence of intraperitoneal air. AP left lateral decube abdominal image analysis practice. Number 1, the distance from the left pedicles to the spinous process is greater than the distance from the right pedicles to the spinous process. The right iliac wing is narrower than the left wing, but you can barely even see the left wing on this image. The right side of the patient was positioned farther away from the IR than the left side. There are snap artifacts in the area of interest and should have been removed. Correction. Rotate the right side of the patient towards the IR until the midcoronal plane is aligned parallel with the IR. Place a pillow between the knees to help the patient to hold this accurate positioning and remove the snap artifacts. All right, and these few images are not in your image analysis book, so you must use your Bontrager's for the criteria. Abdomen oblique, lateral, dorsal decube, and soft tissue neck. Abdomen obliques. Your SID should be at 40 inches. The IR should be 14 by 17 lengthwise. You should always be using a grid with the abdomen. Shield your radiosensitive tissues outside the area of interest. Your part position, you want to rotate the body 30 degrees for both the right and left posterior obliques. You flex the elevated knee for support of the lower body. Raise the arm on the elevated side and place it across the chest. You want to center the vertebral column to the midline of the table or grid NCR. CR is going to be perpendicular to the IR and center the CR to the IR to the level of the iliac crest and vertebral column, as seen in your images here. Collimate on all 4 sides, if possible. Usually you need to use all of your 14 by 17, so possibly maybe side to side if you have a very thin patient. Suspend respiration after expiration. All this information was found in your Bontrager's. Anatomy demonstrated for the oblique abdomen. The entire urinary system is included. All of the symphysis should be included, including the prostate area for males. No motion due to respiration should be evident. Appropriate technique used to demonstrate the residual contrast if you're using contrast. Eval criteria. So the kidney on the elevated side is in profile, and then on the ureter on the downside is in profile and free from superimposition of the spine. Lateral abdomen. It should be centered at the level of the iliac crest and midcoronal plane. Evaluation criteria, anatomy demonstrated. The diaphragm and as much of the lower abdomen as possible should be included. Air-filled bowel loops in the abdomen with soft tissue details should be visible in prevertebral and anterior abdomen regions. Position, no rotation is evident by superimposition of the posterior ribs and the posterior borders of the iliac wings and bilateral ASIS. Exposure, no motion, rib and gas bubble margins should appear sharp. Abdomen dorsal decube, again, this is a decube, so it should be 2 inches above the crest for centering and then at midcoronal plane. Evaluation criteria, anatomy demonstrated diaphragm as much of the lower abdomen as possible should be included. Air-filled bowel loops in the abdomen with soft tissue details should be visible in the anterior abdomen prevertebral regions. Position, no motion as evident by superimposition of the posterior ribs and posterior borders of the iliac wings and bilateral ASIS. No tilt as evident by symmetric appearance of the intervertebral foramina. Exposure, there should be no motion. Rib and gas bubble margins should appear sharp. Lumbar vertebrae may appear underexposed with soft tissue detail visible in anterior abdomen and in prevertebral region of the lower lumbar vertebrae. Soft tissue neck, AP. The central ray is perpendicular to T1, T2, which is 1 inch above the jugular notch, approximately, and mid-sagittal plane. Anatomy demonstrated. The larynx and trachea from C3 to T4 should be filled with air and visualized through the spine. The area of the proximal cervical vertebrae, the lower margin of the shadow of the superimposed mandible and the base of the skull, to the mid-thoracic region should be included. For position, no rotation should occur, as evidenced by the symmetric appearance of the sternoclavicular joints. The mandible should superimpose the base of the skull with the spine aligned within the center of the film of the IR. Collimation borders should appear on both sides, ideally with minimal, maybe a 1/4 of an inch of borders from top to bottom. The collimation field should be centered to the area of T1, T2 exposure. The optimal exposure should be just dark enough to allow visualization of the air-filled trachea through the cervical and thoracic vertebrae. Soft tissue neck lateral. The central ray should be perpendicular to C6, C7, which is midpoint between the lower thyroid cartilage and the jugular notch. The evaluation criteria, anatomy demonstrated, the larynx and trachea should be filled with air and well visualized. Position. Centering for the neck, larynx, and proximal trachea should include the EAM to T2, T3. Note, if the distal larynx and trachea is the primary of interest, centering should be lower to include C3 to T4, T5. The shadows of the shoulders should be primarily posterior and should not superimpose the area of the trachea. Real case studies. Case study number 1. This is a portable abdomen tube view that was ordered on a 103-year-old female for history of abdomen pain. The indication is flat and erect decube for eval of obstruction and abdominal pain, and the physician is specifically asked to have a decube performed. So we always perform a left lateral decube, and here is our supine and our left lateral decube. Case study number 2. This is a flat and erect and/or decube, and a flat and erect was performed. This patient is a 64-year-old female of history of abdomen pain and mass. The indication is nausea. The patient has an ovarian mass. However, we cannot actually see the ovarian mass. We do have good centering for our erect and our supine images. Case study number 3, an abdomen flat on rect or decube was ordered to view, um, and the doctor specifically asked for a decube as well. So the patient is 78-year-old female, history of abdomen pain. The indication is hypotension and concern for perforation. So obviously perforation calls for a decube, a little bit better than a erect abdomen. As you can tell on the decube, you can see a little bit of the artifact from the bed that the patient was laying in the lung there, going across the whole abdomen. Centering looks pretty good. Looks like they performed a left lateral decube, which is what we need for abdomen. And a supine x-ray has also been ordered. Case study number 4, an abdomen flat and erect or decube, and this was a flat and erect performed. This patient is a 36-year-old female, history of abdomen pain and distension. The indication is abdomen distension, and they abuse narcotics. People, when they abuse narcotics, usually have a lot of constipation issues, and this clearly shows that all this mottled looking stuff in here is fecal material that seems to be impacted all the way through their abdomen on the flat and erect. Very painful. But narcotic users usually have a lot this. Case study number 5, soft tissue neck. I didn't get any other information about the patient. Let's just go over some of the centering and all for these. So soft tissue neck. Looks like we could have gotten the mandible up a little bit higher. We do have decent inspiration. You can see the esophagus going down, but you can't see it on the first top several vertebrae. The lateral, it looks like they took a good inspiration. Looks very nice. If we could have depressed the shoulders a little bit, that would have been better. However, you can see soft tissue and a little bit of the bone as well. So it's overall a nice image. You see nasopharynx in there. Case study number 6, soft tissue neck, history of chronic pain in the neck. The indication is a spine stimulator placement. So a spine stimulator delivers electrical pulses to places over the spinal cord, modified by pulses. The pain signals are either not perceived or are replaced by a tingling feeling. The spinal cord stimulation can be used to treat patients with severe and chronic pain, in case you don't know anything about them. However, these are placed usually under fluoro, and then sometimes we do post x-rays as well. And these are some really nice images to show that. Maybe we could have got the mandible and skull aligned a little bit better on the AP. However, the lateral seems to be very nice. Case study number 7, an abdomen. So this is just a simple KUB. The patient is a 23-year-old female, history of abdomen pain and history of malrotation. This was ordered by our radiologist. Anybody notice anything unusual in this image? Yep, the patient is 32 weeks pregnant, and this image is showing a set of twins in the belly. You can see the head of one right down in the middle of the pelvis, and then you can slightly see the second head a little bit slightly up, and then you can follow the spine and see the arms and legs going up into the upper abdomen there. You can also see the fluid where you can see where her placenta would be. It's amazing. This doesn't happen very often because we usually don't x-ray our pregnant patients, so this was a really cool opportunity ordered by the radiologist. Malrotation of the intestine is uncommon and normally found in infants, but occasionally adults. Rare symptoms of malrotation may occur during pregnancy. So obviously this was the issue here. The end.